Oh. And can CPEN folks introduce themselves?
Hi, this is Carolina with CPEN.
Hi everyone, this is Wei Yu. I'm also with CPEM. I'm in the Sacramento office.
Excellent. So welcome everyone. Welcome Behavioral Health Equity Collaborative. This is our monthly Friday call. Today we have great privilege to have Department of Healthcare Services with us, giving us training on AB 470. So just a housekeeping, we are going to record this presentation so that we can have this be available for everyone. If you want to share this video with, your staff or research folks or, anyone else who you think that this is going to be beneficial for, feel free to share this wide. So we're going to have Joseph from Department of Healthcare Services go first, and then we're going to stop the recording, and then we're going to, go to doing some coalition or Behavioral Health Equity Collaborative business and announcements. So that's kind of the agenda for today. So yes, Joseph, take it away.
Okay, let me know if you guys can hear me. Good morning and happy Friday the 13th. I am this will be kind of a two-part thing. I've put together a little PowerPoint presentation, kind of an overview of the application and why it was made. And then I'll give, you guys refer to it as training. I'd probably prefer right now as a demonstration that should get you enough information to understand the basic concepts of using the tool. And I'll begin. So, and I probably won't read word for word. Everybody can read the slides, and I might just kind of highlight some of the fundamental parts of what I'm trying to convey here. But basically, AB 470 for us, we identified two fundamental objectives, and it's to provision high quality, culturally and linguistically competent and accessible, especially mental health services for all eligible beneficiaries. And the bigger part for us, of course, was the development of strategies to reduce mental health disparities. And you see some of the performance kind of measures that we use to look at how we're performing and possible disparities as we look at access to care and timely access to services, language capacity and access, quality, and utilization and penetration. Yeah, let's do that. Here we go. What we met our obligations. So we throughout calendar year 2018, we had a series of meetings with stakeholders in AB 470, and we kind of let them know what we could do and what we planned on doing. We all kind of got a buy-in. People understood that we had to use existing data systems, and understanding too that the kind of all-important SOGI data was still is being collected kind of in an isolated area. So we kind of let the stakeholders know what we could do for the first release of our deliverables. And a big part of it is contained on the open data portal. That's a Department of Healthcare as well as other state departments use this to share publicly accessible data. And that's how we met our objectives, is to get a lot of this penetration and timeliness and similar reports that we did for the performance outcome system. We modified it to kind of stratify it further along demographic categories to meet, the language and sex and different race categories, of course. And so they're contained here. I might go here later to show you how to do it, but here's the link to the data portal, and all you really need to do to view our data sets is to key in the word AB 470. I think, just as a caveat, it's no space. You just type in AB 470 in the search, and you should see all of our 32 data sets. And they're machine readable in Excel or Commons Eliminated. And so those are helpful for sure, and they kind of met our minimum obligations. But what we wanted to do, given time, and this was late last calendar year in 18, we tried to get some kind of visual display. DHCS is kind of used to posting reports, and due to time constraints and the fact that there's so many possibilities with the demographic categories. We just knew that it was really going to be too many combinations, as you see here, and highlight this. So really, if you really think of it, oops, let me go back up. There really could have been, of all the categories selected, if you really want to get critical, you could be like 10,000 possible report combinations for all the language types and race and sex and all that, and different county level reports that we were obligated to. So what we decided to do was to create an application, and that's what we're going to discuss today, a tool that allowed the end user and the public to select what categories and what types of reports they want, and in what counties perhaps, and allow them to do it so that you can have all the report combinations available at your fingertip without having to go through the cumbersome process here at DHCS to get them approved and make them ADA compliant. It's a really long, lengthy process, and we're trying to avoid that. So we use the open data portal to get around it. Right. So here's the description of the application. It's an Excel-based application. What it kind of is it's more of like a turning Excel into a user interface. It takes away a lot of, you're not expected to understand. There's a lot of people that do understand Excel, but you're not expected to be an expert in Excel to use this. We put in a user interface in front of the user, and all they have to do is understand the tool and how it's used to kind of create their own reports on the categories that they're interested in. Another benefit here at DHCS and other state departments, we have this thing called the Public Aggregate Reporting Guidelines. It's kind of a HIPAA type of thing where we're not allowed to display small numbers of patients, basically less than 11. I'm not sure how they came up with that number, but anything that shows patient counts or eligible counts less than 11, we're mandated to suppress that data, and you'll see some of that when I give the demonstration. So again, further description of the report really is there's two major components of the report. As you see here, this is the report display worksheet, and this is really, quote, the report, end quote. You see it's kind of broken down into two pieces. There's a standard chart of different types. This one's a bar chart for penetration and engagement. And then the bottom part is more of a tabular region, which shows the data that really is used to display, to generate the chart. So that's what's ultimately produced when you use the application. Again, we have 5 kind of unique report categories that can be selected. And more or less, this thing is kind of a read-only application. If you save things, you can actually change colors here. You can to meet your needs, but when you bring it back up, you'll see that the application is going to generate our own color schemes that are kind of a guideline with DHCS, where you see a lot of pinks and purples and blues, and that's what our guideline suggests. So we no longer greens and yellows and reds anymore. Kind of standardized across our department. Right, and then the second part is the screen here is a user selection form, and you see that kind of displayed on top of the graph. It comes up, it's a dialog box, and this is really where you make the selection. You can, and we'll go into that in the demo. So you use this to actually generate the type of report and select, your demographic criteria. We'll just quickly discuss the 5 basic types. Especially mental health penetration and engagement rate. It shows the number of clients that are actually receiving one or more service, especially mental health services, in a fiscal year, and by category, depending on what demographic choice you pick. You see here that and you'll see if anybody's used the application and since it came out. I think it was available since January. DHCS, as long as every state department, kind of likes to work in fiscal years when we report. So you'll see every one of our chart types and report types kind of breaks things down by fiscal year, and that's just how we operate. And it's very similar to our performance outcome systems reports that we've been posting for the last couple of years. So And so again, when we talk penetration rate, that means one patient, patients receiving at least one specialty mental health service from our claiming department in a fiscal year. And then the engagement rate is the same people, but that including one or more, but that have received 5 or more specialty mental health services on 5 different dates of service within a fiscal year. The time to step down services it's worth going into a little bit. This is kind of something that can gauge timeliness. So when a patient receives inpatient services, hospitalization, for example, we want to know, generally speaking, when they're discharged from the inpatient services, we want to know the time it takes for them to receive the necessary outpatient or other standard services, follow-up and care. And so what we did here is we obviously want to see a higher percentage of those receiving it in timely, which can be within 7 days, 30 days, more than 30 days, and no step-down services within a fiscal year. And that's something that we track. We want to try to minimize that because it's expected that patients will and should receive step-down services after hospitalization. All right, and then the utilization costs. This one is a very basic. It just shows you, so again on the demographic material, how much average dollar cost per beneficiary in a fiscal year. Again, the tool, the report generator app uses all the 32 data sets, but one of the things that we didn't have enough time was on the utilization, because we also have a lot of broken down by service types, and didn't have time to do that on this first cut of this application. So the only thing that we were able to do this time around was just the overall cost per patient. And then a new thing that is gaining support and popularity that we haven't done, it's kind of new to our division, is we actually, and it was something that was promised to the stakeholders and they seem to want to have it, is a top 5 mental health diagnosis per the ICD-10 data set codes in our claiming system. So it breaks down by, again, you select your demographic criteria and it'll get, and a region like county or whatever, and it'll break down the top 5 mental health diagnoses. And that's kind of interesting because we have yet to do that in the performance outcome system. So this is the first step of that. I hear some feedback there. I hope that's not from me. I'll continue here. And then the last one is the special mental health patient usage. And that shows, I'm sorry, does somebody have a question? Maybe not. That shows how people are entering and staying or leaving the system within a fiscal year. And this is something that we've had in the POS, the performance outcome system reports previously. All right, I think we're almost done with this little thing. Okay, and here's the last slide for this. This is just some overall extra information. The counts, because we have a claim lag, we're only able to report 17, 18 as around this time. And the last number of kids and youth that were receiving special and mental health services are about 267,000 kids, and the adults are roughly 337,000 in, again, fiscal year 17, 18. And again, we intend to, on subsequent versions and releases of our deliverables for AB 470, we are going to, of course, report statistics from our managed care system. Some of that is still being worked on and how we're going to do that. But that's coming up in the next version. I can't promise when the much needed SOGI data will be currently available in enough numbers for us to report on, but at least understand that we are collecting it now and have been for, I believe, several months, if not more. And I need a contact within there to maybe I'll be able to someday we'll be able to provide some early numbers of how many patients have identified in that system. And lastly, there is a web, and I'll deliver this PowerPoint to people on here or make it available so that again, the contact for any questions you might have regarding this presentation or going forward is right here. And if anything is specific to me, I'll get it forwarded to me. So that breaks down a quick PowerPoint demonstration. Were there any questions before I kind of demonstrate a little bit of the report application? Doesn't sound like it?
Hi, there's a question from Gabby, and it says, we can continue the Q&A after your demonstration, but she's asking, how is the SOGI data being gathered? Is this an optional question for patients to opt in or choose to answer?
I don't know that answer. I'm sorry. We can get back to you on that. From our data team, we don't know really it's an isolated kind of somewhat private section of our overall data system. And frankly, right now, I don't personally know. I don't think Chris does as well. What if it's an opt-in? If it's something that's going to be ultimately contained in the meds database? But right now I don't know that answer. I apologize.
Yeah, this is Chris, and we can take that back and see what we can get. That's a good question. We'll see if we can get any answers to that, and I think we can probably send that along when Joe emails the copy of this PowerPoint and our response to that. So I'll jot that down and get back to you guys on that.
Hi, this is Pise from KCCEB. I'm sorry I came in late. Quick questions about the PowerPoint. Are these national data that you're reporting?
No. This is Medi-Cal just for California.
Oh, just for California. And then looking at the percentage of what you share, saying 267,000 for youth and children, and 337,000. What percentage is that compared to the overall clients or community member receiving services?
Yeah, well, I can show that in a few minutes. These are when we say like 267,000 roughly children, youth, these would be a unique patient under 21 who has received at least one service again in the special mental health services, and then you'll see also what the overall, like if you break it down just for children and youth statewide, you'll see the overall number of eligibles, Medi-Cal eligibles in the category. You can. I don't think I break it down just by all kids, but if I do it by biological sex, you can get a rough estimate of what percentage, or you will see the percentage, the actual percentage of over the overall population. So it's really who receives a specialty mental health service and the denominator would be the representative Medi-Cal, eligibles for that category.
And what will be defined as specialty mental health services versus, say, for example, like in hospital setting, they have their integrated behavioral health services. That could be defined a little bit differently. So I kind of want to have a better understanding how that's defined, just for my own understanding.
Chris might jump in. Go ahead.
Yeah, I'll just take right over. Sorry. It basically defined as claims services that are billed through our short bill Medi-Cal system that's primarily responsible for special mental health services, as well as certain inpatient services that are considered special mental health services that are claimed through our big fee-for-service KMIS system. With the tool, it doesn't go into a little more detail on what types of special mental health service descriptions were provided to the beneficiaries, but the actual data sets, the CSV files that are also available in the same areas, you can find the tool on the Open Data Portal. Will go into that deeper level, not quite down to how they're claimed, because it would be kind of a mess if we tried to group beneficiaries at that level, and be hard to get it through our kind of de-identification guidelines. But it goes to, I think you mention in-home based services? That's, a service description that, gets rolled up in those data sets. And we have a really common one just called mental health services, inpatient services, medication support. Those are all displayed in the data sets.
And generally speaking, the patients served in the specialty mental health services are moderate to more severe, issues with mental health. The mild to moderate is generally, by us here at GHS, handled in the managed care. That's just a rough guidelines for that. Okay, if there are no more questions, we'll have the tool display. I assume everybody can see the the tool being used here on my screen. So again, as you see here, there's the selection form here that determines you select the criteria. And this button here, of course, is what you do to generate the report, create report. Again, this thing, it kind of, eclipses the big part of the display. So there's a button up here that you temporarily hide, so you can see what you created. So then you can, again, when you want to go back to creating more reports, you would hit the show and it would expand it back to its original size. So I'll just show a quick one. This is the first one comes up. You see that we got penetration engagement rates statewide. And if I hit this, you'll see that a table is produced and the screen gets updated for all, and you see that I have race category selected. So you'll see the 7 different race categories that we collect in our med system. Again, this is statewide, but you can get down to individual counties if you like. And you'll see here, and you actually see now, because of the suppression rules, first of all, you'll see the little caret, that's our indicator that number was less than 11. And if you can see down here, this little disclaimer automatically popped up that shows that we are not allowed to, we suppressed that data because it was too small. Back to statewide, though, somebody was asking about, I apologize, I forgot who, was asking about the overall beneficiary count. And we'll do this biological sex. It'll give us 2 categories. I'll hide this, but you see that the first fiscal, we'll go to over here for fiscal year 16-17, females, let's say 118,000 roughly, and access the system at least once, and the overall medical eligibility for children are a little more than 3 million. So, and you see that rate comes down, it's displayed here as well, is 3.8% of the Medi-Cal population. So I hope that kind of answers your question. If you wanted to do a overall, you would combine for 16-17, you could add these 2 columns up, and so there's roughly more than 6 million kids, and 250K or more hitting that. So that's one. So again, we'll bring this back up. Another thing on the penetration engagement rate, again, you can do it by all the categories you want. One this is new, of course, is the language. And when you get down to language, because it's so many categories, you have to, if you want to see meaningful data, you have to stay with the bigger size regions, either statewide, LA, some bigger counties, or you're going to see a lot of suppression because there's so many choices. And some of these are pretty, even statewide, some pretty small numbers. But if you stay statewide, you can usually get, I'll just pick the first 6 here. You can pick up to 6 at a time. It's just, and the reason that we have some of that is there's only so much real estate on these charts, and that's why the other limitations on some of the other reports will be is because we just couldn't fit all the information. So you'll have to kind of be specific on what you want. And so let's see if we do it by language here. Those are the selected languages here you see on the screen. And you see when we talk about disparities, you can begin to investigate, or at least be aware that you see here the different language categories, and this is written language, by the way. This is their preferred written language that they identify themselves in the med system. You will see some different penetration rates accessing the system. And you can see some surprising numbers as you change the language, preferred language options in here. I want to go here, and then this is for children and youth. And then we're going to say I wanted to do adults, same language choices. You see something far different. You see here, for example, Cambodians, the language spoken is a pretty relatively high penetration rate, meaning they've had at least one service in a fiscal year, compared to, say, Cantonese. So some of this stuff is useful to understand the different rates. And so we talk about penetration rate here. That's at least one special mental health visit. If we do 5 or more, it's the same category, but they have to be what we call engaged in the system, and that would be the engagement rate. So they had at least 5 visits on different days in a fiscal year. And you'll see that those numbers always go down from the penetration rate. But you'll still see that this many kids, you still see the high percentage of Cambodians as opposed to the other choices here. So that's basically, there's no question, that's kind of the first report type of the 5 basic types. Again, you can break it down with the language to other individual counties, but you're going to see a lot of suppressed data, right? So I'll move on to the second one, and this is talked about earlier, the time to step down services. And again, you can break it down by any category. And this is where you have to get specific because, again, for the 4 fiscal years here, we couldn't, if we wanted to do male and female, there'd be 8 of these individual bar types here, and it would make it pretty cumbersome. So when you want to do things like comparison, so let's hit this and look at the kind of step down category. So as you see here, 52% for fiscal year 13-14 were able to get a service within 7 days. And again, we want to try to keep, we want to see this number low. Again, this is for females statewide. If we were to change the selection to males, probably see some similar numbers. But if you want to compare those two, we have an option here where you could print it. In this option, you want to print. So here's males. I'll pretend like I'm going to print it, but I won't. And we'll close it. And you see that format selection screen went away for that. And to get that back, you would hit this button here. And then maybe you want to print out the females, and then you could take a visual look where you could do that on the penetration rate. You could actually look at the different races. These ones you would have to do kind of individually by a demographic group. I hope that kind of makes sense. That's one way to compare different regions, different race, different demographic categories. All right. So again, the utilization cost is kind of important. Tells you how much money we're spending per patient, per category. Hispanic, let's select Ventura and go. And again, you'll see the cost rise, which is not a surprise, over the fiscal years, 13-14. So here in 16-17, which is the last date that we collected data for this tool, for this run, we're spending roughly $6,000 per client, and the client count is here, roughly 1,500 clients of Hispanic selected race for Ventura County. You can, and again, that's adults. And everything is dynamic here. The title will tell you exactly what's going on here. You see that it says adults here. It says by race, Hispanic, and the county, the region. And so you can really break it down by anything you want, even language if you want. Again, that's that we have all the data that Chris so graciously provided this tool. All right, so that's utilization cost. This is the one that's new that I talked about, and this one's kind of interesting if you play around with it. It shows the top 5 mental health diagnoses for the selected demographic group. Again, race, age, sex, language, choice, adults or children. One thing, though, that we did on this, as you'll see, and this is common with this application, is you can't select something that isn't allowed. And because the diagnosis counts were kind of small and not always available, we had to roll it up to the statewide only. However, you can see, we go adults here, go hit this to see what the statewide female top 5 diagnosis counts, statewide, of course, only. See what that is. And you'll see here, again, the 2 breakdowns on this is this purple line here is at least 1 special mental health visit, again, so it's kind of broken down by penetration and engagement rates. And the top bluer one is diagnosis per, when they come in 5 or more services. Again, for fiscal year here selected is 16-17. So that's females here, and you see the major depressive disorder recurrent, which means chronic major depression is the diagnosis. Break it down here by male, you'll see something completely different. Schizophrenia. Again, this is adult males. And you can, as you select a different group, let's go in children, you'll see something different entirely again. Really, schizophrenia doesn't really occur until young adulthood, generally speaking. And you'll see totally different diagnosis for children. This would be males, statewide, of course, reaction to severe stress. And again, this is done by what's in the claims system for the, is specified by the newer ICD-10 codes. So you can break it down statewide by anything you want, and you will see some interesting diagnoses represented. All right, and the last choice is our patient usage. And I'll have to explain this. I've been doing this for a few years now in terms of help create these reports, and I still have trouble with some of these categories, believe it or not. But let's go statewide. White category, white race category, children, youth. And what this is how they're coming in the system. And again, so if they arrive, that's here, they've just arrived, they've not received any services for a fiscal year, and they're coming in. And because they can't get too descriptive here, and it's sometimes confusing on what these separate categories are, for me, maybe for other people, I put an extra little help button here, which shows, just actually describes what the different categories are, because it's kind of showing who's coming, who's just coming and exiting, who's staying around, who's hanging around the system for more than 2 years, maybe less than 2 years. And again, this, you can obviously do this for more than statewide. You'll see here, if we do Yuba and maybe a category that isn't represented, you're going to see some suppression for sure. And there it is. You couldn't display anything here. And this will tell you that couldn't do it, sorry. So you might have to maybe select a higher represented category, and maybe not, maybe, there you go. So that's really it for the demonstration. I think if there's any training involved, the people that need a little extra info, I am definitely available through my email address to give additional training. But again, when you want to start talking or researching or investigating possible disparities, I think this tool is really useful in showing, the starting point is showing the numbers. These are, again, from the claims, which is really a reliable system because, services are getting paid for and they're being reported. So I think, again, and then when we extend this in future versions where we can not only provide the biological sex, but we can start selecting specific gender identities, you might see some different numbers, which might possibly hint at disparities or of different types for different reasons. But that's basically it. I just wanted to show everyone just kind of how to use the tool, show the basic types, and hopefully I did a bare minimum of that. But I'm open for more questions if anybody has them. Thank
you, Joseph. That was really an engaging presentation, and I don't usually feel very engaged with, data-focused presentations, but that was really great. Thank you.
Welcome.
Now we're going to open it up for questions. I see that there's a question from Lee. Is there an interest to report out on spoken language as well? Sometimes those things vary.
Yes, and we have there are two different choices in our med system, and management chose for this version written, and I can't promise it, but that was an option that we already have that data. I believe, to be honest, that the data sets are actually posted on the Open Data Portal in another system. I can get that information to you in a different location. But yes, and that would be really easy, because then I can make a choice here, two choices, maybe even a checkbox or something, spoken versus written, and I'm sure you would see differences. For the first cut, management chose spoken language of the two choices, but it would be a very easy thing to incorporate on subsequent versions. So that was a good question.
Else has questions?
This is Gabby. I don't have another question. Just wanted to say thanks. That was, other than my computer screen doesn't look great, it was really easy to follow. So thanks for that.
Thank you. Yeah, we tried to make it pretty straightforward, but I know nothing's straightforward. When you're talking about data, I tried to make it as easy as possible, but I know that there's always going to be questions, because what I might find intuitive or what we might find intuitive may not exactly be for others. But I hope I made it easy enough, at least, and then we're given a quick demonstration like this to get people started.
Oh, wait, it's Gabby again.
Oh.
It's Gabby again, sorry. You said during the presentation that, I think you said, you'll notice we can't find information that we're not allowed to. Did you say something like that?
I'm not sure if you're talking about where you see, I'm not sure if you were talking about the suppressed
like
data.
in one of the searches, when you're doing one of the searches, you, I think in passing pointed out, that there are limits, that there are things that you couldn't quite find, or, sorry, I should have asked it when it happened, because now I forgot.
Well,
yeah,
I think go ahead, Chris.
I was going to say, I think I remember that, and that's when Joe was showing off the diagnosis charts, and that's just because we don't have the data sets available at the county level. It's all rolled up statewide, and that's mainly because it's pretty sensitive data, and
right.
And also our de-identification guidelines would just make it unusable too. So statewide is the best we can do for now.
Got it. Okay, thanks.
Mm-hmm.
There's a question in the chat box. It says, is there a way to compare statewide with specific county data?
Yeah, I mean, I think that was some enhancement request previously that can be done. And right now, I think I kind of hinted at a possible temporary solution before we can enhance this application to show maybe a statewide comparison, because I know that's a kind of a criteria that a lot of people want to see, is that, okay, here's a county level for this, whatever performance indicator for this county, how does it match up against the state? And right now, what you'd have to do, and maybe this will, kind of answer the question and be sufficient, and maybe not, but let's say we're looking at, for Ventura, for example, we're looking at, let's go this. Ventura County stacks up here, right? And I talked about the report. So if you wanted to compare, you would have to probably either, print this out or view it at this level, then go back and hit the state and do the same thing. And that's at least a way of making the comparison between penetration rates for race for this and any other report type, and then you do the same thing. You'd print the statewide out. But there's no, again, there's no enhancement that it could easily be allowed unless you have a development staff there that can program in Visual Basic in this example to put something, make additions to the code, which I'm completely open to letting people have access to our code upon management approval. But I hope I answered the question. But I remember that as a request that for future enhancements that they'd like to see, to get the statewide somewhere in the here, or a separate chart perhaps, to kind of show how the particular region or county stacks up against the state. So it can be done, and there's kind of a workaround, I believe, that the answer is you can't do that right now.
So any other questions folks have? We're happy to share out your contact information, Joseph, and we'll get PowerPoint slides from you, and we can send that out to the members. Again, thank you so much for you and your team at DHCS for joining us today and giving us this valuable presentation of this really important tool. And we're looking, forward to keep talking to you and working together and improving the tool and keep communicating. Thank you so much for being with us today, and you can feel free to take off or you can stay for the rest of the call. We're done at 12, but if you probably have other things you need to do, so you can feel free to log off.
Oh, well, thank you, and thanks for having us. And at some point, I would be interested. I see there's another assembly bill you're working on. I forgot the number, 500 something. I would be interested in knowing what that is. But again, thanks for having us on our team. And I will be hanging up now.
Thanks.
And I'll send out the PowerPoint. Thanks, everybody.
Thank you.